All right, so it's January 2014, and welcome to the Neurology Neurosurgery Combined Clerkship. I'm John Leigh, and we're going to a couple of objectives for this goals for this clerkship. Number one, at the end of the month, you should be comfortable with common neurological disorders: headache, stroke, Parkinson's disease, epilepsy. And you'll see them, but to that end you'll also have your vignette sessions, and you should become familiar with those common disorders that primary care doctors and everybody have to deal with. The second objective is to be fearless about your neurological exam. And all those things that you weren't sure about, nail them down this month, either with your chief president or attending if you can, just get all those details sorted out. What I'm going to do for about the next hour is just go through the exam. You already know the neurological exam, but I just want to kind of focus on things that will help you, make it more time optimal and organized, and show you a few things that might help when you actually carry it out. Now, I'm going to talk a little bit about cognitive function and so forth, but I like to start with the cranial nerves because I think they're the most fun. And how do we test the first cranial nerve?
Smelling.
What? Ammonia?
Coffee or vanilla?
Coffee, yeah. You don't, nothing too pungent. One nostril at a time. What are the common causes of loss of sense of smell?
Congestion.
Common cold.
Old age.
Age. Unfortunately. There are other things, rare things, but you see it up to head injury. Let me just ask you, so I had a patient who had a head injury, severe head injury, he was unconscious for 2 weeks, came out of it. A young guy came to see me because he said, "Doc, since the motorcycle accident, I've not had any sense of smell. Now I get terrible smells, awful smells like burnt rubber, and I get confused when it happens." So what was going on? And I tested him, he had no sense of smell. Well, actually, he had suffered lacerations to his temporal lobe and he was having seizures. And everybody knows, I think, about deja vu, preceding prodrome before seizures. But in fact, in his case, his skin smelled. Well, we're mainly visual creatures. So let's turn to the second cranial nerve. And you may have had the experience already of working with an experienced clinician who takes a fairly meticulous history, but does a very rapid examination. And you wonder how they sort of get away with it. Well, they're testing a hypothesis. They came up with several hypotheses during the history, and they go and test them on the exam. But they know what to look for. And when it comes to the second cranial nerve, the thing that guides you on knowing what to look for is the anatomy. So let's just briefly review that. And I usually have a case student draw this out, but I've spared you that this morning, the embarrassment. So let's just briefly go through the visual pathway. So this is the left eye, this is the right eye. Here's the nose. And what's this structure here? That's the optic nerve, right. And this here? Optic chiasm, that's right, and that's where the hemidecussation, not well drawn, takes place. What's this part here? Optic tract. And then there's a synapse, isn't there? The visual thalamus, what's that called? Lateral geniculum. That's very good. LG. And then this longest part of the visual pathway, what's that called? Well, part of it is Meyer's loop, but more generally, optic radiations, that's right. So let's consider the effect of a lesion at each site, then we'll know what to look for when we do the examination in a couple of minutes' time. So first of all, if we talk about ischemia at the front end of the visual system, the anterior optic nerve and the retina, What do those patients tell you when they come into your office or into the emergency room? What do they say?
Got dots or spots of vision loss, like scotoma.
Well, they get a visual loss.
Or complete visual loss.
It could be complete.
Don't see things on one side.
One or both eyes. One eye. This is monocular visual loss. Does it come on gradually or suddenly? Fairly quick, pretty quick, all right? Usually within a matter of seconds. And yes, it may take the whole eye out, but if it doesn't, is there anything about it? The visual pattern of visual loss? Well, it's often a shutter coming down or a shutter coming up. And it may stop halfway, so-called altitudinal defect. And that just reflects the blood supply, the way the blood supply in the central retinal artery, but also in the ciliary vessels. It may be complete. But it may be transient, although it may be permanent, it may be transient. When it's just lasts for a few minutes, we have a name for that. What is it called? Amaurosis fugax, that's right. Just means fleeting blindness. And Dr. Darif objects to it because one of those is Greek, one is Latin, and that's which. But it, like angina pectoris, it has a sort of meaning of its own. It means when people talk about amaurosis fugax, it's transient visual loss due to vascular disease, front end of the visual system, usually vascular. And it comes on rapidly and lasts for just a few minutes typically. But you can usually see if there is a relative defect, it's above or below the horizon. If we go back to the optic nerve, let's talk about a common cause of loss of vision with optic nerve lesions. What's that? Young women. Optic neuritis, inflammatory demyelination as in multiple sclerosis, that's correct. And now, if you get an optic neuritis, what is the type of visual defect that they complain of when they come into the office?
They don't see the outer quadrants because of the neurological facilities.
Well, the MLF has got something to do with eye movements, not vision, but I think the main thing is that they lose their central vision. Somebody used the word before, scotoma, right? I heard somebody say. And classically, the loss of vision is a central scotoma, which is an island of blindness in a sea of vision. And if amaurosis fugax comes on pretty fast, and then takes several minutes to go away, with optic neuritis, how long does it take to come on? A day or two, typically. And they may go lose vision completely. And if you're in that terrible situation of seeing a young woman in the emergency room, she's almost blind in one eye, and she says, "Doc, will I get my vision back?" What do you say?
Most likely, yes.
Yes. The optic neuritis treatment trial, like 90+% got 20, 30, or at least in 6 months, but it takes months to get better. There's one other distinguishing feature between amaurosis and optic neuritis. Do you know what it is? Medical students use it. Pop this one up. Amaurosis fugax is painless. Optic neuritis, they often have some discomfort when they move their eye. It may not be prominent, but it's presumably due to the inflammation. Now, if we work our way back to the optic chiasm, the area you're probably more familiar with, what is the lesion that dings the optic chiasm? Pituitary tumor usually comes from underneath, and it's going to affect these crossing fibers, so it's going to affect nasal retina here, nasal retina here, so it's going to cause things out on the sides, and that's going to cause bitemporal hemianopia, that's right. Now, just a refinement that the pituitary tumors press from underneath, and have you noticed how everything is reversed with regard to the visual system? So if things pressing underneath, it's typically the field effect is more dense up here. What's that? That's bitemporal superior quadrantinosis. Things that press down on the optic chiasm, like craniopharyngioma, low. Behind the chasm, from there to the back of the head, you get one type of field defect. What is that? It's the commonest in neurological practice. Homonymous hemianopia, right? It's one of these funny words again. So, homonymous hemianopia. It just means on the same side. This, if you will, is heteronymous hemianopia, but nobody ever calls it that. Now, it's a long way from just behind the optic chasm to the back of your head. This is visual cortex, V1 as they call it nowadays. And we need a few tricks so we can identify if we've got somebody with homonymous hemianopia, if it's the front end or the back end. And one fact is that the axons from each eye, by the time they get back here, you want corresponding points on the retina going to the same columns in the visual cortex. That's how you can get binocular single vision. But they're not in register here. It isn't until they get back here they're in register. So lesions of the for example, the optic tract will produce a homonymous defect, but it might be quite different in the two eyes. We say that's incongruous. And then a second useful thing is this, in the optic radiations. If you look at the optic radiation, so the visual system starts here, it's around here, and then goes to the LGN. And some of these fibers go temporally, and this is the lateral ventricle that I'm sort of showing in green, and there's a temporal horn, and some of those fibers sweep around the temporal horn. That's Meyer's loop. Okay, and when we have temporal lobe lesions, we get what we call in the trade homonymous pie in the sky. All right, more strictly speaking, homonymous superior borderline synopsis. But the important thing is this is temporal lobe. Temporal lobe. So those patients of Dr. Luder's who are having epilepsy surgery, temporal lobe, that's what you go looking up here. That's where you go looking for the field defect. More commonly, perhaps in clinical practice, is the parietal fibers, and you see this in middle cerebral artery occlusion, causes an inferior defect. So at the bedside, you demonstrate the lesion there. One last point before we just start examining, and that is that lesions up to and including the chasm can make you go blind. Not very common, but it does happen. But lesions behind the chasm do not. So if you've got somebody with homonymous hemianopia and their visual acuity is down, there's something else going on. They've got something else besides homonymous hemianopia. They've got a, I don't know, macular degeneration or something else going on. Okay, so let's apply these things. I'll be very democratic here. So I'm going to sit here. I'm going to hand you a visual acuity card. Step right up. Okay. And go ahead and test my. I'm just your average bloke in the emergency room. Now, you're going to test my visual acuity, right? Go for it.
Yeah.
Stand right up. Come on. Come over here so you can see what's going on.
Okay. So I want you to cover your stroke right now with your.
That's not that. That's the way to cover it now. Okay.
And I'm going to hold this for 6 feet.
Yeah, that's a Snellen. You can't that's a fog chart. That's correct.
I want you to read, see if you can read the lowest
I
level.
can't read anything without my glasses.
Okay. Do you have your glasses?
No, I left them at home. And that's usually the case, right? If they come to the emergency room in a hurry, they leave them behind, and some people just don't bring them. You'll move.
Okay.
There is a trick, right? There is a way to parry it. Then I'm just bringing it right up, which is not very effective.
Okay, I'm not
Think physics. Anybody? Here's a pinhole. A pinhole will overcome any refractive error. Now, I'm so used to dealing with patients who forget their glasses that I've got a real pinhole. So that's just it's just a bunch of pinholes. But you can make one yourself. You just take a card, spang a few holes in it. Check it. Those of you who wear refraction, it will overcome any refractive error. So the main point is you're going to test one at a time with correction. If there is no correction, make yourself a pinhole and see if they can use that and see if it improves vision. Okay? Have a seat. Yes, sir. Stand up here for me. Here. you're locked out, you're going to pass it wrong. So just face me, and we're going to test visual fields. And basically, there are two situations when you test visual fields. First of all, in the patient who has no visual complaints, that's most of the time, right? So we'll do that first, the screening test, if you will. And the important thing is you use yourself as a control. And so, just cover that eye. That's good. Look right at my eye. And before we get started, how many fingers?
4,
4. Okay, look right here. And tell me how many now,
3,
now, now,
4,
now. Good. Cover the other eye. Right here. Here we go.
2, 3, 3, 2.
Good. Now what am I doing? I'm presenting stimuli first of all in quadrants because that's the way that the system breaks down. And you might say, well, why do you not just say, tell me when my finger moves? I find that unreliable. Because somehow, yeah, I see it. But in this, I'm asking it to make actually a judgment, a discrimination, if you will. Now you might object, you might say, well look, he hasn't got a field cut, he's got a neglect due to parietal location. And I wouldn't argue with that. This is a sensitive way to do it. Now, let's say, God forbid, he walks in with a visual field defect. Then in that case, what you need is a small red object. And perhaps the most useful is a match. A match, or you can use a red pointer if you got one. But red is the color that goes. For example, those patients who've had optic neuritis, and they get better 6 months, you say to them, you know, is your vision back to normal? They say, well, not quite. And you ask them what's not right, they say the color red. Red is the color that goes. So, cover that eye again. And if you have somebody, let's say he's got a central scotoma, then he would, as I bring it in, actually it disappears in the blind spot there, but you can see sort of there actually. Red spot, and you'd say, it's going, it's black, it's gone. It's come back, it's reddish over here. So with a match, you could map out this visual defect. Now it takes a cooperative patient, and also they sometimes have difficulty if they're lost central vision holding gaze steady. But if you give them a big field, they can usually do that, and you can map out. They can sometimes even map out for the visual defect for you. It's a small red object. But recall that everyone, one eye at a time, they're going to check the visual fields by showing the fingers. Okay. So, now come up and test my pupils and tell your colleagues what you're doing.
All right, so just pupil instruction.
Pupil exam.
All right, so we're going to see if we have if they're reactive to light to accommodation, and if they're reactive to light in the one eye and the
Very good. Any instructions to me?
she's looking up and towards me as much as you can.
Well, pardon me, but is that best? What are the two stimuli in the pupils? Light and accommodation. So if you're scientists, you want to fix one, vary the other, right? So what I do is have patients look at something at optical infinity, sometimes difficult in a small room, but fortunately I can see right through the window to the building over the street, and I'll look at that and I'll fix my state of accommodation. Okay. Now, before you start flashing that flashlight, how about measuring my pupil size? What's the best way to do it?
Not actually sure.
Well, I'm lousy at estimating pupil size. That's why I rely on this. Use that. That is reliable. Okay. Go for it. Okay, so I'm looking at optical infinity. You can hold it right up. Hold it right up.
4 and 4 in optical infinity.
Thank God. Okay, right. You have to turn this. You have to turn this thing on. You have to flip it up. It's a bit strange. There you go. All right. So tell your colleagues what you're doing.
So we check for pupil constriction in the ray shine the light on there, and then also in the
So the direct and the consensual pupillary light responses. Very good. So now, there's a better way of doing that. I'm going to show you. So have a seat here. And I'm going to show you a test called the swinging flashlight test. Then I'm going to draw you the anatomy, then I'm going to show you the test again. So I have a look at optical infinity up there. I measured the size of his pupils, and he's about 5 or 6 equal. I then check that each eye responds to light, which it does. And let's say, God forbid, that he's got a right optic neuritis. I'll shine it in this eye. If it's not complete, he will constrict. I'll move the light over to the other side. A very strange thing happens. Sorry, let me start again. I'm going to edit that out. So I shine the light into his left eye, and the pupil constricts. And then I bring the flashlight over to his poor eye, which is already constricted consensually, and it dilates up. And so, as I go like so, so it'd be constrict, dilate, constrict, dilate. Okay. Now, I'm just going to use the board. So, what's happening here? The important point is that unequal pupils don't occur with afferent defects. If you've got unequal pupils, it's efferent. It's from the third nerve on out. Okay. You can cut an optic nerve, and the pupils will still be the same size because of the consensual response. And that takes place not through the cerebral cortex, which is important for a couple of things, but through the brainstem. So this is the brainstem, the midbrain. There's the aqueduct, and the evidence is that the axons split off just after the LGN and go to the brainstem. And the important thing is that inputs from one eye go to both sides of the brainstem. They go to both third nerve nuclei, the Edgerton Westphal said, and they go off and supply parasympathetic supply to the pupil. Now, let's say we've got a right optic neuritis. I shine the light into his left eye. This constricts. This one does as well. I'm not looking at it. I then bring the flashlight across, and light can't get in, so both pupils dilate. So that's the swinging flashlight test, and it's very useful if you've got somebody who's confused and you want to figure out if they've got loss of vision in one eye or a kid. It's a simple way of just playing off the direct and consensual. So look over there again one more time. So after we've done the preliminaries and made sure that each pupil responds, then I swing it like this, and it would be sort of like constrict, dilate, constrict, dilate. Okay, thank you. What is Horner syndrome?
Sympathetic denervation to the...
Loss of sympathetic denervation to the eyes and the face, right? What is the actual syndrome composed of? What are the 3 features?
biases and hypnosis.
Right. So let me tell you that Horner syndrome is a very useful finding. I go looking for it all the time. You see it in the cancer population, you see it in patients with carotid dissection, you see it with brainstem strokes. It's very helpful. And not just pancreas tumors, you see it in head and neck cancer. Here's the deal. It's tough to diagnose. And this is why it's tough to diagnose. First of all, the anhydrosis. Lots of luck. You know, you kind of drive your finger, maybe there's a difference, or you can pull your tuning fork across the forehead. It's something. If they're really in a hot room and sweating, then you can see it. The ptosis. The ptosis is not like a knock your socks off ptosis when the lid comes right down, like you see in myasthenia gravis or third nerve palsy. It's a mular muscle, right? It's just a little bit of ptosis. Guess what? A lot of people have got a little bit of ptosis, particularly older people. They get this lindyhiscence, and the lid comes down slightly. So it comes down to the pupil, and this is the trick. You've got to take him into a dark room. I sometimes walk him into the bathroom if it's really dark. And then the normal people will dilate up, but the Horner's people will not. And you get a big anisocoria, unequal pupils. You peek with your flashlight and you can see that it's really brought out the difference. Aside from pharmacological testing, that's by far and away the simplest thing to do. You just got called, paged 3 times from the emergency room. They've got a patient down there who's got a fixed dilated pupil, slightly confused, or at least non-English speaking, shall we say. And they're panicking. Why are they panicking in the emergency room? That they've got a patient with a fixed dilated pupil who's got pain and confused. What are they worried about?
Herniation.
Herniation is one thing, pressure of the temporal lobe on the oncus, there is the temporal lobe pressing on the third nerve, that's correct. And the other thing is aneurysms. Aneurysms will do that, posterior communicating aneurysms and so forth. But beware of the fact that people will put drops in their eyes that put atropine-like substances in their eyes, either they've been prescribed or for whatever reason, and so you just should be aware of that possibility. And actually the way to test is to put another drug in their eyes, and that's pilocarpine, which is available everywhere. It's used for glaucoma. If they're pharmacologically blocked, that people will not know. Okay, so let's move on to eye movements. Would you like to come on up here? There are 2 situations when we test eye movements. Actually, let's just bring you out there. I'm going to work off this board. It's easier. There are 2 situations when we test eye movements. One is in patients who complain of double vision diplopia. And then there's your routine exam that you do in patients got no visual complaints. That's the usual situation, right? Most of the patients do not. Let's deal with the double vision situation first. And you should not be intimidated by it. If you just talk to the patient, usually you can figure out what's going on. What you need to know, first of all, is there double vision due to misalignment of the eyes? Because you can get monocular diplopia. You get double vision from one eye. And it doesn't mean they're cookie. It just means that usually they've got a refractive problem, which would be a cataract or some other problem. And the way you can, so just covering one eye, if they cover one eye, they still got double vision, that's monocular double vision. And actually it often improves with a pinhole. But the usual situation is they have double vision, and you cover one eye, the double vision goes away. That's the usual. And to interpret it, you do need to know just the pulling actions of the extraocular muscles. And if the eye is abducted, then this is the lateral rectus muscle here, and this is the medial rectus, which pulls the eye in. It's the vertical ones that can be slightly confusing. In the abducted eye, this is the superior rectus, and this is the inferior rectus. With the adducted eye, it's inferior oblique and superior. So now, say you've got somebody who walks in and they say you've got double vision. So, and you establish it's because their eyes are misaligned. It may be obvious just when they walk in, but if it's not, you want to ask them if it's a horizontal or vertical deviation. And then if it's worse, if they look to right, left, up, down, near or far. Usually, it'd be pretty obvious. If it's a horizontal double vision, most times it's 6-nerve palsy. Usually. There's a lot of other things as well, myasthenia and so forth, but often it's 6-nerve palsy. If it's a 3rd nerve palsy, well, remember the 3rd nerve supplies a lot of stuff, right? It supplies the pupil, it supplies the lid, and several muscles. The tricky one is the 4th nerve, trochlear nerve, and those individuals complain of double vision of looking down. When I go down the stairs, doc, that's when I get double vision, that's 4th nerve. So, having just talked to them, what you want me to do is just take them to the range of movement, and first of all do it one eye at a time. Cover your right eye for me. So look at my pointer here. So it'll be medial rectus, lateral rectus, superior rectus, inferior oblique, superior. You do that for each eye just to make sure that the eye moves. Sometimes you get a surprise. And the really critical testing is to take them to these basic cardinal positions, they call, and ask them, is the double vision worse? So if I took him over here and he said, yeah, it's much worse now, it's on all likelihood going to be a 6-nerve palsy, and you probably might see that the right eye's not turning out if it's a real 6. Okay? So you take him through these ranges of movement. I'd ask them at each point, and usually it will pop out what's going on. You look also at the pupil, you look at the lids, make sure there's no ptosis. and putting it together usually can make the diagnosis. If not, then you call it in and we do special testing. But that will clear up 90% of the patients. Just a simple examination will show what it is. All right, so now let's go through the testing of the patient's got no visual complaints. What we're going to test is fixation, looking for nystagmus in particular, saccades, the rapid movements, smooth pursuit, we sort of just did it, vestibular, head movements, and vergence. First of all, fixation. So look at my pointer here, and he holds his gaze quite still. There's no nystagmus. And then take him into eccentric gaze and look for gaze-evoked nystagmus. He doesn't have any. He holds gaze nice and steady. If he was intoxicated, whether it be with alcohol or with benzodiazepines or anticonvulsants or entry movements, you might get gaze-evoked nystagmus. You can try it yourself. If you have 2 or 3 pints of beer, you'll find you'll get gaze-evoked nystagmus because the cerebellum, alcohol's GABAergic choritin, suppresses the GABAergic mechanisms of the cerebellum. If you have nystagmus in center position, particularly if it's vertical, downbeating, think cerebellum, okay, unless they're intoxicated, they need an MRI scan usually. All right, saccades. Saccades are the rapid movements you make all the time. So look at the pointer, look at my nose, pointer, nose, pointer, nose, pointer, nose. And you see them asking to look between 2 fixed targets. And he makes rapid, prompt, rapid, accurate saccades. If he had, say, Alzheimer's disease, then you might find that there'd be a latency. He wouldn't immediately look when you asked him to turn his eyes. If he had some degenerative disorders affecting the brainstem, the movements would be slow. And then finally, if he had cerebellar disease, there might be inaccurate overshoot, just like you overshoot on finger-to-nose test. Pursuit movements we just did, but we'll do them again, and these are nice and smooth. People who are intoxicated or have cerebellar disease make jerky pursuit movements. Vestibular, the deal about the vestibular system is this. It's a backup for vision. Vision is great, we love it. It's 3D, it's motion, it's color, Hollywood loves it. But guess what? It's really slow. From a neurophysiological point of view, if you think about it, from a flash of light to an evoked potential is 1/10 of a second. It's a long time, 100 milliseconds. And it's the retina, which is slow. The vestibular system is 10 times faster. So now, if you look at the back there, and what I'm going to do is just move his head like that, not very far, but quickly. He stays on camera. I'll now epitomize for you what would happen if I lost variety of function. If I did a rapid head turn to the right, my eyes would go with the head, and then after a moment the visual system would kick in and I'd make a corrective movement. It's the correction you look for. And then finally, of course you can do it with caloric testing. You probably saw in the lecture that we use that occasionally. And we mainly use caloric testing actually in the ICU setting. Look at my pointer, and he converges his eyes, he constricts his pupil, and the shape of his lens changes as accommodation. What we can't monitor that. Okay, go and have a seat. We're going to talk about the 5th cranial, the trigeminal nerve. Very important. If I give you one test, and only one test, of 5th nerve function, what would that be? I love this part. For a long time, I used to do it on medical students. Then my son was a medical student here, and he said, "Dad, you can't do that. You can't go poking things in medical students' eyes. They pay all this money." So let's see you do the corneal reflex on me. So stand up, and the thing is, you've got to have a look at the ceiling, and you've got to actually touch the cornea, not the sclera. Go for it. Go on. Do it. Come on, you're a doctor. Come on. Do it. Right on the front. Right on the front. Yeah, that's it. Good. And then the other side. So you have to have a look up. Good. And then I usually ask them, does it feel the same on the two sides? Sit yourself down. All right, what's the next most sensitive test for fifth nerve function? Pain. So, and you go V1. Are they similar on the two sides? About the same, right? And V3. Now, why do this? Why use nociceptive stimuli? Why use corneal? Why not just be a nice guy and have a little bit of cotton on the face? More specifically, where do the nociceptive fibers, the pain fibers, go when they hit the brainstem? What happens to them? That's right, one of God's little gifts to neurologists. They take a dive. Spinal tract of 5. It's quite unnecessary, but thanks, you know. What happens to the fine touch in the face? What happens to those? Main, trigeminal nucleus, and straight up. Boring. Okay. Let me ask you a couple of questions. How far up does the V1 division go up? How far up does it go, the extent? We can't easily test here, but it's the vertex. Up to vertex. And oftentimes, you know, people with functional plates conveniently stop at the hairline. Also note the angle of the jaw is not trigeminal, it's C2, right? Just look at that picture in your anatomy book, it's very, very cool. What else does the trigeminal nerve supply? No, not tongue. Muscles and mastication. Clench your jaw. Clench your nose, okay? Open your jaw and push it over against my hand. That's pterygoid on the other way. And a quick screening test is just to have them open the jaw and use your thumb or something as a fiduciary and just make sure it opens mid-line. Then the last thing to do is the jaw jerk. And so half open your mouth, just halfway, like that. And you just not have a jaw jerk, which is pretty normal. I'll tell you when a jaw jerk is useful. If you have somebody with very brisk reflexes in all four limbs, like they have a spastic quadripresis, often the question is, you know, is it in the neck, is it due to cervical disease, or is it north of the neck, is it in the brainstem or internal capsule? If they've got a brisk jaw jerk, it snaps back at you, then that obviously makes it rostral to the neck. It's in the brainstem or north. Okay, thank you. Next, you're next. Right. I'll sit down. We're going to talk about the seventh nerve, the facial nerve. But when I test the facial nerve, I ask myself two questions. Question number one, is there a facial weakness? What's the most sensitive test?
Smile.
That's right. Show me your teeth. Really, you're looking here at the nasolabial folds. Really try and really do it, okay? And sometimes they go one before the other. That's and sometimes it's not easy, but that's the place to look. Number two, if there is a facial weakness, is it an upper motor neuron lesion or a low motor neuron lesion? What is the test to make that distinction? Raise your brow. Raise your brow, and you just that nice. You take your glasses on the same. And then you can test other muscles. Scrunch your eyes up tight, orbicularis, arcally. Moxon inner blade cheeks up. And purse your lips, orbicularis oris, and platysma. What other function does the seventh cranial nerve supply? It actually does supply this venous, that's right, but something else. Taste, right? Taste, anterior 2/3 of the tongue, chord and tympani. If you're going to test taste, do it properly. You need to go and bring the patient's tray, get some salt and sugar, go to the nursing station and bag a Tylenol tablet, which is acetaminophen, which is bitter. And they have three cups, and just make a goop, and then you put labels out, bitter, sweet, salty. Have them stick out the tongue with gauze, and then put it on one side of the tongue, because usually it's just one side, they point to the label. It's fun to do, but etc. What is Bell's palsy? Well, yeah, it's the quintessential lower motor neuron facial weakness, and it's, quote, idiopathic, but it often follows viral infections. You see it in the spring, right? And it may be complete when they come into your office. What do you tell somebody who comes in with Bell's palsy?
It'll get better.
And they usually do. They usually get better in a month or two. What is the main issue in terms of taking care of them?
Eye dryness.
Sorry?
The dryness of the eye.
Absolutely right. You've got to look out for the eye because they can't blink, and I actually use a send to the optometrist to get it. Okay, so that's it. But remember the two test questions. Is there a facial weakness? Showing your teeth. And if there is a facial weakness, is it upper motor neuron or lower motor neuron? Raise the brow. Come and get your hearing test. Isn't it amazing how if somebody loses vision, they charge off to the doctor. But if somebody loses hearing, it's a significant other that complains about it. It's correct, it's absolutely correct. And so my reason for bringing this in is you've got to test it. You've got to test hearing. It only takes a moment if it's normal. So just a finger rub, you hear that, that's fine, but do it. Now, if there is hearing loss, then you want to pull out your tuning fork and get serious. And perform the two tests. But before doing the two tests, what I do is sort of get in the ballpark, and I just use myself as a fiduciary to get an idea of just how bad the hearing loss is. And this is the way I do the two tests. First of all, the Rene, just turn your head this way. So I ask which is louder, 1, which is air conduction, or 2, which is bone conduction. And air conduction is usually louder than bone conduction. And then the Weber or vapor test, which is actually a very useful test, I think, a sensitive test. You just ask them, do you hear that in one ear or the other? And people with just small amounts of hearing loss will be able to tell you if there's an asymmetry. Let's just consider briefly two scenarios. Let's say she has a right-sided hearing loss, right ear hearing loss, following a bad attack of the flu. She's got an effusion in her middle ear. We do the screen test, it's certainly down. We do the tuning fork to get an idea of how bad it is. Then we do the two tests. In this case, bone conduction is better than air conduction. And the paradox is that the Weber vapor goes to the bad ear. Okay. Scenario number 2, she has hearing loss on that side due to a tumor on the 8th nerve, an acoustic neuroma, more properly a vestibular schwannoma. And we do, after doing the preliminary test, we do the two specific tests. On this occasion, air conduction is better than bone conduction, which is the normal situation, but now the Weber vapor goes to the good ear. So those are the ways to sort it out. And that's in your electronic syllabus, those two scenarios. But remember, just test here and there. Thank you. Come down here, I'm not going to impose on you a gag reflex. You'll relax like that. Have a seat. In actual fact, the gag reflex is very variable from person to person. I think the key thing is to establish the key things are with a Q-tip to touch the posterior pharynx and see that they feel it in the posterior pharynx. And I have them say ah and make sure the uvula goes up in line. And my pragmatic approach to it, and we see a lot of patients, for example, coming with strokes, and often the issue is, is it safe, and so forth. And I just give them a small cup, really small cup of water, usually the one after they come in, just to see how they cope with it. If they can't cope with it, then you need to do your modified variant swallow and all that stuff, swallowing evaluation. Can you say pa 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 pa? La 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 la. So pa 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 is face, la 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 is tongue. So can you say candy?
Candy.
Really hit it, candy.
Candy.
And that C, the hard C, is dependent on posterior pharyngeal wall closing. And so individuals who have a weak posterior pharynx, and you see it also in the palate kids, they can't say handy. They can't take those hard C's. I have to psych myself for this. Can you say E, and that's opposition of the vocal cords, and it depends on the recurrent laryngeal nerve, which is sometimes seen with for example, lung cancer. And can you say kitty, 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 kitty?
Kitty, 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 kitty.
You
Kitty, 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 kitty.
That's
kitty,
that's
kitty,
even and regular, and patients with cerebellar disease can't do that. It's kitty, 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 so-called scanning speech. All right, let's just take a look inside a little bit. All right, I'm going to not do the, just open your mouth, just say ah. I see it's usually goes up midline. But now I'm going to just focus on his tongue for a moment. And his tongue is of normal bulk, and there's no fasciculations. What are fasciculations?
But like quivery.
Quiverings. What are they due to? What causes a fasciculation? Innervation. What's actually firing off with a fascic? What actually is it? No, those are fibrillations. Yeah, we can't see them. Yeah, but it's a motor unit. So that's an anterior horn cell, and all the muscle fibers that it supplies. So fascics down here are big, right? Smaller here, and smallest around the eye. Now, from a practical point of view, what does the finding of fasciculations in the tongue mean from a diagnostic point of view? Not a good sign, is it? Often means ALS, motor neuron disease. However, having said that, let me just clarify a few things about benign fasciculations, which we all get, right? Benign fasciculations is that same muscle over and over again, isn't it? Here, and particularly periorbital fasciculations. Fasciculations in ALS are often. Okay, stick your tongue out and wipe it from side to side, quickly, side to side, very good. Continue to press there and press over here. And your strength and movements are fine. We bypassed the 11th nerve. Let's just go back and look at the accessory nerve. Shrug your shoulders, that's trapezius. Now watch carefully for sternocleidomastoid. Turn your head that way, press, and note that when he turns his head to the left, the right sternomastoid is contracting. It's one of the few muscles which affects the movement to the opposite side. Okay, so now when we come to the motor exam, this is a sort of scheme for you. The first thing, actually, often we do when we barrel into a room with a patient in the emergency room, even before we start, particularly in the setting of stroke and so forth, we have certain screening tests that we do, which are very useful. And they're useful, by the way, if you seize up during your examination, you can always do them. And the one that's most popular is to look for pronated drift of the arm. So it's hands up like this. And what you really look with our eyes closed, what you're looking for is that. Not that, like that. Which implies a weakness on one side. Another sign that we've used here and developed, Dr. Darragh brought it, with Emeritus actually originally from Norway, is to ask them to orbit their forearms around this, like so. I'll now epitomize for you what you would see with somebody with the left hemichresis, like that. And actually the residents here evaluated it and wrote up, it's quite sensitive, not quite as specific as drift or extensive plantar response, but it's useful. Inspection. Two things about inspection. First of all, we're looking for spontaneous movements. We already talked about one, which is fasciculations of the tongue. And this is where you see the esoteric stuff in neurology, right? Korea and so forth. But there's one adventitial movement we just need to just digress for a minute on because it's so important, it's so common, and that's tremor. And for practical purposes, there are two causes out there. We get curbsided all the time to look at patients with tremor. Forget intention tremor that you see in cerebellar disease, because it's very easy to diagnose that because they have limbic ataxia. But there are two leading causes of tremor out there. What are they? What are the two? Yeah, so Parkinson's disease and essential tremor. And let's just, now of course, if somebody's got Parkinson's disease, you go looking for the other things. You look at the clinical findings, bradykinesis, increased tone, and so But across the room, you may be able to distinguish these if you look for certain things. And what are the findings that point to essential versus Parkinson's? Anybody know? About three things. Right, so essential trigger is typically symmetric, fairly symmetric. Parkinson's is asymmetric, and Parkinson's disease in general is a very asymmetric disease. You show me somebody with really symmetric Parkinson's disease, I'll say drugs. You know, that's one. All right, what else? There's one singular thing about Parkinsonian tremor that really sets it apart. At rest, very good. At rest. Whereas essential tremor is typically with posture or action. And let me just say what I mean. So, if you've got somebody really at rest and they've got a tremor, then it's usually Parkinson's disease. Essential tremors are worse when you have it hold out the hands. Actually, Dr. Riley likes to do it this way. That's a nice way. That's when they really get. Think of the caffeine shakes. And you see essential tremors are genetic. Some people have it mildly. Usually, if they're medical students, they don't go into surgery, though there are medications for it. It's souped up in certain disorders. You see it in hypothyroidism, for example, the disease, pregnancy will rev it up. And certainly certain drugs, particularly the psychiatric drugs, lithium and valproate will rev it up. And also the patients on bronchodilators, the chronic lung patients, they're often, you'll see the shakings as well. And there's one more thing, and that's the nature of the tremor itself. This is one of these weird things we start with. Pill rolling. What on earth is pill rolling? I've never known it. I've been in the game for 40 years. I still don't know what pill rolling is, but it's like that. It's a compound tremor, right? And you often see it when they're walking. And so this is what we call a compound. It's fairly low frequency, compound and low frequency. Whereas this is a high frequency of 5. Think again of the caffeine shakes, okay? And then there's the one distinguishing feature that I always ask the patients about. I always get told off when I ask the question. What's the question I ask the patient? Yeah, do you have a glass of wine or a beer? Does it something? I don't drink, Doc. But it's certainly alcohol will suppress essential treatment. Just that much effect. Okay. Well, where do we check? Where do we look for wasting? What places to go looking for? Small muscles of the hand, correct? Here, jump muscle, deltoids, right? And a lot of them look at the anterior border of the tibia to see if there's so-called saber. The sharp tibia implies wasting. If you suspect wasting, get out your tape measure and look for symmetries. For example, if you think there's a quads wasting, take it from the patella, measure up so many centimeters, do the girth, do the same distance here, measure the girth there, and see it. Usually they're pretty similar. They're fairly symmetrical. Okay, man, if you don't mind, if you can come and sit. So, what do we mean by tone? What's a good working definition of tone? Just a sort of clinician's definition. Resistance to passive movement, or stretch, passive stretch. And for practical purposes, as neurologists, we're interested in tone increases. Now, you're reading the books, and it's certainly true that cerebellar patients may show high reduced tone, but it's tough to demonstrate. We're mainly interested in tone increases, and there are two types: pyramidal and extrapyramidal. And for practical purposes, extrapyramidal tone increases, think of basal ganglia disorders, upper limbs. Pyramidal, mainly lower limbs. Okay. So if you've got somebody who you think might have a Parkinsonian disorder or basal ganglia disorder, you're really interested in the upper limbs and whether there's increased tone. And you can do it, for example, if you're looking for cogwheel rigidity, you can do it at the elbow. I prefer it at the wrist. And remember, you're always looking for asymmetry, so you go from one side to the other. And And then the way to really bring it out is to have, just do this preliminary, is to have them reinforced. So open and close this hand, open, close, open, close. And that often will, you get click, 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 you'll feel it. And then you do the same with the opposite side to see if there's an asymmetry between the two sides. That really brings out the asymmetry by having to reinforce just a repetitive movement. You can do a variety of things. I just have to open and close the hand. It revs up the motor pool, basically. Okay, now pyramidal tone increases, and mainly lower limbs. Could you slip off your shoes? So actually you can demonstrate them sometimes on the upper limbs. If you pull like that, you get a catch, so-called clasp knife. It's a clasp knife stiffness or rigidity, and we're back to what we mean by a clasp knife. I think it's like a sprung knife, but it often isn't very prominent. You see it more in kids, I think. What we're mainly interested in the lower limbs, and let's say that we're in the bed situation now, and so we want to make sure that they're well covered. And then, first of all, I take them by the thigh, just move side to side. You can see it's lagging. There's a lag there. It's not moving en bloc like that, as it would if he was spastic, if he had pyramidal tone increase. And then if you try and lift the leg off the bed, his ankle stays down. But if somebody who's spastic, you can lift up the whole limb just by lifting up the thigh. And then that most useful of signs, which is clonus. And the trick with clonus is to bend the knee. You've got to bend the knee. That's why it's important that it covers here. And then just get nice and supple, then step. Okay. I'll now simulate for you what clonus would look like. So you get it nice and loose, and then it would go like that. That would be clonus like that. Okay. All right. Power. There's a lot of muscles, and sometimes you've got to test a lot of muscles. And if you do, you shouldn't be shy about getting out of the book. I was trained by the most intimidating man in American neurology, a giant, Fred Plum. But he would have no problem about getting out his MRC book at the bedside if there's a, this is a very old tattered version with the photographs, if there was a complicated brachial plexus lesion or something, just, get it out. What I'm going to show you now is essentially screening testing. I'm going to show you muscles which are important, and if you test these muscles, you'll not miss much. However, in the course of the exam, if you find weakness in any muscles, then you've got to get serious and start looking at others. Get out a book and go through them. For example, if it's a shoulder problem, look at all the muscles around the shoulder girdle and so forth. Okay, so always test deltoid, like that. Keep these separated slightly, and press down the femur. It should not be able to break that. Okay, that's very important. If there's any weakness of deltoid, you want to look at all the other muscles, supraspinatus, infraspinatus, and so forth. But if you're okay, then go to always test biceps, and it's palms to the ceiling, like that, and pull up like so. That's biceps, and you normally should just look at the muscle. If you press down, this is triceps. Now, at the wrist, you can test them all, but by far and away the most sensitive and important one is dorsiflexion. This goes in everything. Keep it back, don't let it press it down, hold them at the wrist. You should be able to break that. That goes with all manner of processes, central and peripheral. In the hand, you've got 3 nerves. You want one muscle for each nerve. Median, ulnar, radial, right? So first of all, median. So commonly affected the carpal tunnel syndrome, people who are using mouses and repetitive movements. And the important thing here, the simplest test is opposition of the thumb. So the thumb to little finger, and you're pulling the thumbs away from the little fingers, okay? Opposition of the thumb. Second nerve, the ulnar nerve, commonly being at the elbow, right? And the best way to test that is with abduction of the little finger, abductor digiti minimis, that little finger I'm feeling, comparing on both sides. You see I'm comparing the sizes of nerves. Then finally the radial nerve, typically seen actually in the emergency room setting in drunk patients who've fallen heavily asleep on their humerus and the spiral groove and hit their radial nerve, and they come in with Savignac palsy. They can't extend their hand, so fingers straight out and out here. So to recap, the essential muscles, you want to test deltoid, biceps, triceps, extension of the wrist, and then one muscle for each nerve. Opposition of the thumb for median nerve, abduction of the little finger for ulnar nerve, and extension of the fingers for the radial nerve, okay? If you find any abnormalities, then you want to get serious. And also you're guided also by the history. Obviously, the shoulder movements, you want to go through in detail all the muscles. In the lower limbs, you need to test sometimes all the hip muscles, but always test hip flexors, iliopsoas, knee up, please. Give it up, right up, and this one up. Now sometimes you need to test the others, gluteus medius, gluteus maximus, and the adductors, but always do iliopsoas. It goes in everything. It goes in stroke, it goes with muscle disease, nerve disease. It's really important muscle to test. At the knee, you want to test both hams and quads. First of all, the hams. Keep it bent, don't let me straighten it out. Okay. That's good, and then quads. Go ahead, push it out. Okay. Now, in the foot, at the ankle, I should say, you can test them systematically, but I'm going to show you a quick screening test now. Stand up for me, please. Stand right up on your toes, high up on your toes, right up on your toes, that's good. And now walk on your heels, walk on your heels, that's good. And oftentimes, that's, if it's normal, that's fine, sit down. If there is weakness there, then often one of the common things you have to consider is peroneal nerve palsy, and then the important thing is to test eversions of push your foot out against it. Okay, that's very quite common in foot drop, we need to test that. So to recap, in the lower limbs, you want to test iliopsoas, hip flexors, the hamstrings, the quadriceps, stand on toes, stand on heels. But if there's anything found, then you want to focus on those other muscles. Coordination. You're all familiar with this. Let me just show you a couple of things though. So finger to nose, touch my finger, then your nose, and the trick is to have them reach. When they're reaching, that's when you start to see the so-called terminal dysmetry. Have them reach out, and do it quickly. And then that's when you see this. When you test heel to knee to shin, the trick is to have them do it slowly. So if you do this, if you have it slowly, that's when they start to show this diaphragmasis. And you can have them do this. You're familiar with all this testing, that's fine. And by the way, I should just say that the examination is not complete in the year 2014. There's plenty of opportunities for new testing. I told you about the orbiting test, but there's always an opportunity for developing new ways of testing the nervous system. So it's not set in concrete at all. Reflexes. Some are easy, some are not. Let's just take a look at them. Could you undo a button here? Biceps is usually pretty straightforward. If you get the arm like that, you don't relax, you can actually put your hand on the tendon there and just drive it. And I can feel it going there. It's about 1+. And it's very important to go and do it on the opposite side because people vary enormously and they do tendon reflexes. Normal subjects I'm talking now, but they're usually symmetric. So you get somebody who comes in, a very nervous person, coming into the doctor. They have very brisk reflexes, but they're symmetric and the toes go down and everything else looks okay. So you take it in context. And if it's difficult to get the reflexes, so clench your teeth, and that really bring out reinforcing. The lower limbs, you can have them do this to super their reflex. Triceps is the toughie, right? So it actually shouldn't be too difficult because there's a big tendon sitting there, right there. You haven't just not hang like that, and usually can get it quite well. Once again, you go going from side to side, comparing the two sides, and make sure there's no asymmetry. That's the thing. If you see asymmetries, that's the thing that will bother you. Brachioradialis is supplied by the same sort of roots as biceps, but it is dependent on the radial nerve, so it's useful to test it. And you just have them like this and just test like this. And then you can see the muscle go there and something on the other side. And then finally, sometimes I find it useful to do the finger jerks, and the reason is that if you've got a low cervical lesion, a disc for example, then you can sometimes see an asymmetry, and you can either just do it by tapping the tendons like so, or like that. And once again, comparing the two sides. There is a test that you'll read about in the book, Huffman's test, in which you take the finger and flick it like this, and the response is like that. And I don't find Huffman's a very reliable sign. Okay, the lower limbs. Usually most medical students feel comfortable about doing the knee jerks, and the true and tried way to do it is with the legs hanging over the side of the examination couch. But if you're just sitting, you can do this. Put your hand on the quads, and you can just tap like this. I can feel it. His knee jerks going there. The tricky one is the ankle jerk, right? That's the one. So let's just look at it for a moment. A couple of things that might help. If they're in bed, make sure they're covered. Bend the knee. You've got to bend the knee, okay? And then what you do is you just get it nice and supple like this, and like that. That should usually do it. But by far and away, the best way to get the ankle jerk is as follows. If you don't mind, a little bit of cooking. Can you? This might be a little, though it's hard, I think I find it slightly easier. Try that one. It's a little bit more even in here. Is that okay? So now you've got both ankles side by side here, and you can see that quite easily on the two sides. You can compare them. Thank you. So if you've got somebody with a sciatica, for example, it's often very important, obviously, very important to determine if they get compression of the S1 root, and that's a simple way to sort it out. And so now the moment comes where you kindly remove the sock. Dr. Verbinski's sock. The challenge of the plantar response is to distinguish between the extensive plantar response and tickly toes, isn't it? So I'll show you a few ways. I don't use anything too sharp. I actually find that tuning fork or keys, car keys, not sharp ones particularly. And what I do, they really should be in bed. They should be supine to do it properly. And the thing is, I first of all put my hand here and press on the thigh, and I feel tensor fascial lata. Remember tensor fascial lata? Tensor fascial lata kicks with a true extensive plantar response. And then the thing is to slowly come up. You're doing very well, like so. And this toe goes down. And as opposed to, very good, as opposed to tickly toes, which is a sudden withdrawal, it takes a second or two for the extensive plantar response to get going. It does. And slowly this thing starts to go up, and the other toes may fire, and you feel tensor fascial lata kick. There are other ways, Chaddock and so forth, of stimulating. I don't think that anywhere as reliable as the Verbinski response. That's the one I go for. I just work at it. Yeah.
How hard are you pushing?
How hard is it to push? Firm. I mean, not to induce. The mistake I think is people use very sharp things. I think something that's said people. Car keys are great. Just slowly come up and see. Yeah, I think that's right. You need to just do it. It's actually, you've really got to lean on it. And I'd say, I know this is medieval, but just hack it out. It's a very important sign. It's a great sign, actually. Okay. A word or two about sensory testing. I'll be honest with you, I think you can waste a lot of time doing sensory testing. You know, it should be intelligently applied. If you touch, is that sharper than this? You can spend a lot. Oh yeah, maybe there's a difference. You can spend a lot of time. Here's my approach. First of all, if there are no sensory complaints, okay, and you even on your review assistants, go for the long axons. Those are the ones that are going to be dinged by neuropathies. And in diabetes, of course, you use a sharp stimulus, and you just come up, and they tell you if it's getting sharper. The gloves starting. In other individuals, a sensing test is showing position sense, so that's up, that's down. Close your eyes and say which way. And perhaps the most sensitive of them all is a vibration as a screening test. But some normal elderly people will lose a little bit of vibration, so you have to take it in context. If they have sensory complaints, then test a hypothesis. For example, is this a root lesion or is it a peripheral nerve lesion? And I always carry with me a picture of the nerves, so I can compare dermatomes due to root levels with peripheral nerves. So you're testing a hypothesis. That is the way to do sensory testing. And if there's a spinal cord lesion, you want to come up and see if there's a level, a sharp level when you go sharpness, and then that gives you the spinal cord. Those are, I think, the main things. With a cooperative patient, an pertinent exam can be very, very valuable, but oftentimes it's not the central part of the examination. Okay, so now, just a little bit now about, stand up for me, please. Just walk up here. Gait, swings his arms, turn around, turns in two, walk quickly down there for me, please. Turn quickly, does this and that, walks with a narrow base, swings his arms and does a quick turn. Okay, now can you turn and walk one foot in front of the other for me, please? And he does this nicely. Right. And stand with your feet together. And close your eyes. He does this fine. So now, you're okay. So, in fact, you can sit down, put your shoes on. Patients with cerebellar disease walk with broad-based gait, also with peripheral neuropathy. Patients with Parkinson's disease cannot walk in tandem. Patients with Parkinson's disease have difficulty getting going, and then once they get going, they can move. And they also, if you give them a pull, they fall backwards, they retro-pulse. When you stand with your eyes, well, there are three things that we need to hold this erect posture that we've had since Lucy. And that is vision, balance, somatosensory. Close the eyes, vision's gone. Stand on a soft pillow in stocking feet. It takes out most of your somatosensory. Try it. And just close it. Then you're running mainly on your ears. So there's a way to chip away that. Okay, thanks. All right, so let's just a word then about cognitive testing. Do the mini-mental or the MOCA tests. The reason I say that is they're not transcendental, but they are standardized, and they're also reproducible. And so if a medical student sees a patient who has some suspicion of cognitive failure, and another student sees it 6 months later, you can compare. It's useful. If there is a doubt about memory failure, much more sensitive than any test is to talk to the significant other. Pick up the phone with media. They will tell you very quickly if there's memory failure. That will save you a lot of time. I often ask the residents when they present something, how did Mr. Smith do on the test of life? And they say, what? The test of life in America is the best job we've ever had. This is a very occupation-oriented society. And so, for example, you may come across a guy who's a landscaper, but you know, he runs his own business, you know, and he keeps his own bills and so forth. It gives you a good idea about personality. With respect to language and dysphasia, it's become more complicated than it was. We originally had the Wernicke and Broca's type, and Norman Gershwin, a giant of American neurology, forged into a lovely scheme, but it was a serial scheme. And guess what? The brain is a parallel process. It's like the internet, right? So the best way, if you come across a patient who has difficulty speaking, is to, first of all, just describe what you find. Are they fluent? Can they understand simple instructions? My favorite is put your left thumb on your right ear. Can they repeat? Can they name? And can they read and can they write? And then fit that defect into the whole context of the neurological examination, whether they've got a hemiparesis or central ostinates. I think those are the main things. Anything I've left out, Ray?
No, I think you got everything.
Any questions? The thing is, practice it. Practice it and get your residents and chief residents to check your slips. If there's something you're not sure about, you know, ankle jerks or something, just have them, just do it. I haven't said anything about ophthalmoscopy. The thing about ophthalmoscopy is you've got to practice it. So practice it with your buddy or a significant other, okay? And be systematic. First of all, find the optic disc. check, look at its margins, look at the vessels as they come out, see if they're blurred or if they're clear, and then look around the rest of the retina to see if you see any hemorrhages or any other mischief. But practice is the key thing there. And ophthalmologists, neurologists are using ophthalmoscope less frequently, but it's really important, especially, I think, in an emergency room situation. Good luck to you all.